My name is Paul Harker Murray. I'm a pediatric oncologist at the Medical College of Wisconsin. I worked for 5 years in Dallas before moving back to the Midwest to get closer to my family. And I'm grateful for George Buchanan for giving me the opportunity to speak here on the Hodgkin and non-Hodgkin lymphomas through COG, and one of the co-chairs of the upcoming clinical trial for relapsed Hodgkin lymphoma, which will be an international trial. I'm going to talk about Hodgkin and non-Hodgkin lymphoma. I'm going to work very hard to highlight the differences between the different lymphoma subsets because that will help on the exam. These slides all emphasize the ABP content, and there is an index in the back saying which content questions are addressed by which slide. Now, just a reminder, the ABP content specs haven't changed since at least 2007, so I will be slipping a couple things in that are 2017, but I'll highlight those as well. For your studies, this is how I organize the slides: Hodgkin lymphoma, then non-Hodgkin lymphoma, and then some cheat sheets to summarize the major differences at the end. Pediatric lymphoma has many subtypes. As you can see, there's 4 different histologies for classic Hodgkin lymphoma, then there's the nodular lymphocyte predominant, then a bunch of names of non-Hodgkin lymphoma, and I have never found this categorization very helpful. Instead, the way I think about these is that the lymphomas can be immature or mature, and T-cell derived or B-cell derived. So immature T-cell derived is T lymphoblastic lymphoma. Immature B-cell derived, B lymphoblastic. Anaplastic large cell is the mature T-cell derived lymphoma, and all of the rest are mature B-cell derived lymphomas. They're all differentiated based on their morphology, their immunophenotype, and their cytogenetics. And you need all 3, and that line probably appears about 3 times in this talk. I know I just told you one slide before that there's a lot of different types of lymphoma, but in order to feel more self-important, I have lumped them all together. Lymphoma is the 3rd most common cancer in children aged 0 to 14, and the #1 pediatric malignancy in the narrow age group of 15 to 19 years. The epidemiology is important. As you can see on the left, non-Hodgkin lymphoma is in blue, and you can see it is more common than Hodgkin lymphoma in younger patients. But once they get older, Hodgkin lymphoma becomes the #1 cancer in 15 to 19-year-olds. And importantly, the age at which those lines cross is about 10. So if they're less than 10, NHL is more common, and if they're greater than 10, Hodgkin is more common. Hodgkin lymphoma may actually be multiple diseases or at least have several different causes and can be triggered by genetics, infection, and altered immune function. If you have a family member with Hodgkin lymphoma, other family members are at increased risk, so there may be a genetic predisposition. If you have an immunodeficiency, you're at increased risk of Hodgkin lymphoma, so it can be seen in sarcoid ALPS, ataxia telangiectasia, and HIV. We also know that Hodgkin lymphoma seems to be associated with dysregulated immune function, and patients can present with ITP, autoimmune hemolytic anemia, autoimmune neutropenia, or nephrotic syndrome. And lastly, there's a role for infection. In the childhood form of Hodgkin lymphoma, so age 0 to 14, it tends to be associated with low socioeconomic status, larger families, and early intense exposure to infections. In contrast, in the young adult form, so patients age 15 to 35, they tend to have been higher socioeconomic status, a single family house, small family with less siblings or playmates, and a late exposure to infection. So in this population, in contrast, more siblings and preschool infections are protective. So maybe decreased antigen exposure is the cause here. EBV can cause some cases of Hodgkin lymphoma, and the evidence for that is that many patients have high antibody titers against EBV. The EBV genome is found in and localized to the Reed-Sternberg cells. LMP1, which is shown in the figure, resembles an activated tumor necrosis factor receptor superfamily, and that signals through NF-kappa B as well as the PI3 kinase and AP1 pathway. And NF-kappa B is constitutively active in Hodgkin Reed-Sternberg cells. That is the driving mutation. EBV expression does vary by different subtypes listed here, as well as different ethnicities and different populations, so especially younger age and lower socioeconomic status. They do want you to know the Hodgkin-Reed-Sternberg cell and its variations. So in the upper left, this is the classic Hodgkin-Reed-Sternberg cell with, the two nuclei and the owl's eye. There's also the Hodgkin cell, which is just the mononuclear variant of the Reed-Sternberg cell. Multinucleate variants, shown in the lower left, also exist. And then they're also called lacunar cells, where you've got this sort of isolated nucleus. And what's basically happened is this is an artifact of formalin fixation, which is pulling the rest of the cell in. In terms of the different histologies of non-Hodgkin lymphoma, nodular sclerosing is by far the most common histology, and that's what you see in blue. It's most common at any age group, but the buzzwords for this are going to be young adults. The next most common is mixed cellularity, and the buzzwords are less than 10 years of age and advanced disease. Then it's followed by lymphocyte-rich and then lymphocyte-depleted. And I'll talk a little bit more about nodular lymphocyte predominant later. But as you can also see in this slide, EBV is associated with different histologies to different degrees, but almost never in nodular lymphocyte predominant. Again, the histologic subtypes of the classic Hodgkin lymphoma are based on the architecture, fibrosis, and the inflammatory infiltrate. However, the different histologies are not used in risk stratification, so the test may very well just say classic Hodgkin lymphoma. This is nodular sclerosing. You can see at the gross level it does seem to have a thick capsule, and there's some sclerotic collagenous bands. On histologic cross-section, you can see these pink, thick sclerotic collagenous bands. And again, this is the most common histology, and the classic presentation is lymphadenopathy involving the neck and the mediastinum. Again, thick capsule, thick sclerotic collagenous bands. And then at high power, you can see the Reed-Sternberg cells kind of in the middle with a background containing multiple other cells, including lymphocytes and macrophages, eosinophils, and rarely plasma cells. This is mixed cellularity Hodgkin lymphoma, which does not have those sclerotic bands. You see scattered throughout many Hodgkin-Reed-Sternberg cells, some with one nucleus, some with two, but it's mixed cellularity. So there's also lymphocytes, eosinophils, plasma cells, and histiocytes. This is the second most common form. It's usually patients less than 10, and EBV is frequently involved. This is lymphocyte-rich. You can see the classic owl eyes kind of hiding down in the lower right, and then it's the cytokines that these are releasing are pulling in sheets and sheets of lymphocytes. And lastly is lymphocyte-depleted, and there's some large, bizarre-looking malignant cells, few lymphocytes, and very, very disorganized fibrosis. This is very rare in children, and it is common in adults with HIV, and it is nearly always associated with EBV. Comparing the malignant cells of classic Hodgkin lymphoma and nodular lymphocyte predominant, on the left are the Reed-Sternberg cells. They've got a binucleate, thick nuclear membrane, pale chromatin, large eosinophilic nucleoli, and then the LP cell for nodular lymphocyte predominant that used to be called the LNH cell. This is a mononuclear variant, and it has this convoluted irregular nucleus, and just try to remember the word popcorn. They look kind of crumpled up like popcorn. This is a low power of nodular lymphocyte predominant, and you can kind of see the nodular architecture here. And at high power, you see these popcorn cells surrounded by sheets of infiltrating lymphocytes. The immunohistochemistry is important. Classic Hodgkin lymphoma will be CD15 positive and CD30 positive. You remember it's CD30 positive because of brentuximab vedotin. And nodular lymphocyte predominant tends to be 15 negative, 30 negative, but CD45 positive. So remember, 15 plus 30 equals 45. The spoiler, of course, is primary mediastinal B-cell lymphoma, and that has 30 positive and 45 positive, but not 15. But we'll get to that. Nodular lymphocyte predominant Hodgkin lymphoma, this will be one slide on it. It's only 5 to 8% of Hodgkin lymphoma. Its incidence is higher in prepubertal patients. About 75% of patients are males, and this picture is actually the one to remember. It's an example of a patient with localized disease, no B symptoms, it's not bulky, it's not systemic, and it's EBV negative. The good news is that surgery alone without chemotherapy may be appropriate for stage 1A. The bad news is that a small proportion of them transform into diffuse large B-cell lymphoma. So the buzzwords for this are young, male, contained, and asymptomatic. If anybody wants to break out into song, now's a good time, YMCA. Yeah, I didn't think so. Classic Hodgkin lymphoma versus nodular lymphocytes. So this is the comparison between the two. I've already talked about the malignant cells. The origin of these cells for Hodgkin, for classic Hodgkin, is it's a pre-apoptotic germinal center B cell. So these cells have undergone clonal Ig rearrangements, but they've mutated and they're unable to code for the Ig variable region. So they should have had apoptosis, but they didn't. For nodular lymphocyte predominance, it's a germinal or germinal center B cell. These are antigen selected. The variable regions are intact, and they were trying to transition into a memory B cell. I've mentioned the phenotype. For classic Hodgkin, the B cell markers are downregulated, but for nodular lymphocyte predominant, they do show B cell markers. And the pathways are important mostly for classic Hodgkin lymphoma because those are the best defined. So in classic Hodgkin lymphoma, NF-kappa B is activated, and that downstream results in increased BCL2, which is anti-apoptotic, IL-10, TGF-beta, which suppress the attacking immune system. And there's a number of ways to activate NF-kappa B. You can do it by being infected with EBV and expressing the latent membrane protein 1, which, like I said, is the activated TNFR superfamily member, or it looks like one anyway. For the EBV negative patients, they often have mutations that inactivate I-kappa B, and I-kappa B is the negative regulator of NF-kappa B. And they all express CD30, which is a member of the TNF receptor superfamily, and again, it signals through NF-kappa B and AP1. And increased CD30 expression is associated with higher stage and the presence of B symptoms. And this is a picture just showing the redundant ways that you can get from either CD30 or EBV LMP1 to NF-kappa B activation. This is one of those, hey, by the way, it's 2017 slides. So on the top is a MHC class 1 expressing cell. We'll call it a Reed-Sternberg cell. And down below is a T cell that wants to be activated and kill it. And you see that T cell are activated through ligation of the T cell receptor, and there's downstream signaling, which results in T cell activation, cell growth, effector function, and survival. Well, in the periphery, there's ways that we don't want an excessive inflammatory response. We don't want an infection to turn on an autoimmune disease. So there are ways that we turn off T cells. And one of the ways we do that is the PD-1 receptor on T cells. Ligation of the PD-1 receptor activates SHIP2, which results in the dephosphorylation of ZAP70. And interestingly, cancer cells, not just Hodgkin but many others, have learned to overexpress the ligand for PD-1. Hodgkin's expresses it on the Reed-Sternberg cells, of course, because that's the malignant cell. And in Hodgkin's, genetic testing shows that the majority of these patients have different 9p24-1 alterations, which can be duplication or increased expression. And this results in increased PD ligand 1, PD ligand 2, and this ligation results in T cell anergy, growth inhibition, and the inhibition of effector function. So essentially, PD ligand 1 on Reed-Sternberg cells is a don't kill me signal. It turns off infiltrating T cells. Again, 2017. We know about this interaction, and now there are checkpoint inhibitors, and these are blocking antibodies against both PD ligand 1 and PD-1. They restore anti-tumor immunity, and both PD-1 inhibitors and PD ligand 1 inhibitors have been proven to be highly active in Hodgkin lymphoma, even in patients who have shown that they're resistant to multiple chemotherapy regimens, including bone marrow transplant. Okay, so the clinical presentation of Hodgkin lymphoma, classically it is painless cervical or supraclavicular lymphadenopathy, and there's a mediastinal mass present in about 2/3 of patients. They may have constitutional symptoms. The B symptoms, which are listed here, are prognostic. The other constitutional symptoms, like fatigue or pain following alcohol ingestion or pruritus, those are interesting but not prognostic. As you have seen, the lymphoma cells are only a small amount of the tumor mass, and so there's clearly evidence of ongoing inflammation, and you can have a high CRP, sedrate, ferritin, copper, and they often present with anemia of chronic inflammation. And again, as I've mentioned before, they also can show up with immune dysregulation, autoimmune neutropenia, hemolytic anemia, ITP, and nephrotic syndrome. A couple pretty pictures so you can take a breather. 15-year-old female with 2 months of cervical adenopathy. This is stage 2A classic Hodgkin lymphoma, and she happened to have nodular sclerosing phenotype. What's the differential for this? This is a Saturday night transfer, It was a 90-kilo, 13-year-old male with orthopnea, shortness of breath, and an anterior mediastinal mass. The fellow went charging into the room to tell the family the differential diagnosis for their potential cancer, and I went down to see the pediatric radiologist. It turns out this was just a normal thymus in a 13-year-old, and the history that was taken kind of led everybody astray. The excellent resident said, "Do you sleep on pillows?" And the boy said yes, and so they said orthopnea. "And do you get shortness of breath running up several flights of stairs?" And he said, "Well, yes, I do." So they wrote shortness of breath. Well, it turns out the kid sleeps on pillows because he plays video games in bed, and he gets short of breath running upstairs because we all get short of breath running upstairs. Okay, so the point is the differential diagnosis for a mediastinal mass has a number of non-malignant conditions, including some very benign things like a thymus, but as well as a bunch of malignant ones, some of which are lymphoma and many of which are not. So keep these on your thought process for a differential. The evaluation, we do a H&P, of course. We look for B symptoms and lymphadenopathy. It's always important to rule out the emergent presentations like superior vena cava syndrome and superior mediastinal syndrome. We always do CBC and a chem profile. I don't know why we get inflammatory markers, but we get inflammatory markers. They actually are prognostic in adults' risk stratification. We do chest x-rays, we do imaging, and currently an FDG PET scan is the metabolic study of choice. We prefer an excisional lymph node biopsy, not a fine needle biopsy, because we really are interested in the histology and the architecture. In 2007, bilateral bone marrow biopsies were indicated if the patient had B symptoms or they had stage 3 or 4 disease. In 2017, FDG PET is most often used to image marrow. So about FDG PET, FDG is a radioactive glucose analog. It correlates with proliferation in tumors undergoing anaerobic glycolysis. There are some drawbacks to it. You do get false positives, including inflammation, thymic rebound, and brown fat. But we currently use it for staging at diagnosis in response to therapy. Currently, based on the 2014 Lugano classification, a complete metabolic response is considered complete remission. And this is especially useful in patients who have nodular sclerosing, where you've got those thick sclerotic tissues, and those don't disappear right away with CT. It is more sensitive and more specific than bone marrow biopsy for bone marrow involvement. PET scans are not appropriate for off-therapy surveillance for recurrence. Most relapses of Hodgkin lymphoma are detected clinically less than 12 months after completing therapy. Early detection of relapse does not affect overall survival, and surveillance imaging is expensive and results in unnecessary radiation. Believe me, it is hard to convince a family, yep, you're in CR, you're done with therapy, no more imaging. But it's probably the right thing to do. Here's an example of using a PET CT for anatomic localization and staging at diagnosis. And you can see here that there's diffuse marrow involvement in both proximal femurs as well as the bony pelvis. We use it to monitor response to therapy. The current standard, based on the Lugano criteria, is the 5-point Deauville scale that compares the uptake in the tumor site to the mediastinal blood pool as well as the liver. It's a little bit tricky to interpret depending on if you're in a clinical trial or using established therapy. Number 1 and 2 are always considered a complete metabolic response. 4 and 5 are considered always having active disease. The reason 3 is a little bit iffy is a 3 at interim analysis when you're using standard therapies like ABVD or ABV-EPC. That's usually considered a complete metabolic response. But if you are conducting a de-escalation trial, some experts would argue that a 3 might not be non-metabolically active enough because they don't want to avoid undertreatment in a de-escalation trial. And I think I have this reference listed at the end of the talk. Not all that is PET avid is malignant. This is an 18-year-old with glomerulonephritis who was referred for diffuse PET avid submandibular cervical axillary and inguinal lymphadenopathy. But what you can see about this is that it's very, very symmetric. His nodes were enlarged, but they were mobile and non-tender, and they were symmetric, and Hodgkin lymphoma isn't like that. It progresses along contiguous nodal groups, not diffuse and systemic like this. So it turned out that he had HIV. So again, when you have systemic lymphadenopathy, you need to think about other things on the differential. This is the Ann Arbor staging classification. I am not going to read all of the words on here because I was dinged on it in a previous talk. But what's important about the Ann Arbor classification is that it's useful for stratification because Hodgkin lymphoma spreads predictably along continuous nodes until the disease is very advanced. We do substage classify Hodgkin lymphoma as, A for asymptomatic or B with B symptoms. And we also acknowledge whether or not there is bulk disease, which is listed down here. The presence of B symptoms or bulk disease are risk stratifying in Hodgkin lymphoma. They are not risk stratifying in non-Hodgkin lymphoma. These are some unfavorable prognostic factors at diagnosis: advanced disease, the presence of B symptoms or bulk disease, or extranodal disease are all poor prognostic factors. And then, of course, during therapy, a slow or incomplete response is also a bad sign. When we risk stratify, unfortunately, there are several large pediatric consortium, and they all risk stratify just a little bit differently. So looking at what they have in common, you get something like this. These are the commonalities between groups. So it's very easy to say that stage 1 or 2A without bulk is low risk, and 3B or 4A or 4B are high risk. But these are the things that are common. In terms of principles of therapy, as we've already heard today, multimodal therapy using multi-agent chemotherapy is standard. Radiation is standard, especially for high risk, but I'll talk about some exceptions to that. Survival is high even for patients with advanced disease. And therapy is risk adapted, meaning the disease severity determines the intensity of the therapy. So the disease severity is measured by both the stage and the prognostic factors at diagnosis, as well as the response to therapy during treatment. Modifications include adding a modality, such as in more intensive chemotherapy, or decreasing or omitting a modality, like decreasing radiation. Because our cure rates are so high, we're not shooting for better cure rates now, we're shooting for good cure rates, but decreasing the late effects. So decreasing cumulative doses of chemotherapy, substituting less toxic agents, and in terms of radiation, decreasing radiation fields and giving more precise delivery. This slide was courtesy of David Hodgson from the University of Toronto. In the olden days, they learned they could cure Hodgkin lymphoma with mantle radiation therapy, which is shown on the left. The radiation field is in yellow, and the lymphoma is that blotch kind of in the middle above the heart. And what you can see here is we've nicely radiated the lymphoma, but we've also radiated both lungs, both breasts, the thyroid gland, and the heart. And so that certainly predisposes to a lot of long-term toxicities. And then moving forward, we've transitioned to involved field radiation therapy and involved node radiation therapy. Currently, there isn't a single standard of care. These seem to be kind of dynamic and changing as we evolve our clinical trials. But traditionally, radiation doses have been 20 to 25 gray in 1.5 to 1.8 gray fractions over 6 to 8 weeks. Certainly, modern trials support the elimination of radiation based on staging, response to therapy, and specific chemotherapy backbones. These are several published trials which have shown in a randomized way that patients who are in a CR after a certain number of cycles of therapy, there was no benefit to adding radiation. Unfortunately, we currently don't have a widespread consensus as to who should or shouldn't be treated with chemotherapy alone. But it certainly can be omitted in certain circumstances. This is a list of the late effects of Hodgkin lymphoma therapies. This is another one that I'll let you guys read to yourself, with the exception that I want to highlight female infertility in Hodgkin lymphoma is associated with abdominal radiation, so radiation to the ovaries, as well as alkylating agents. But for males, well, we don't radiate the testes for Hodgkin lymphoma, so it's just alkylating agents. Historically, this infection with encapsulated pathogens, in the old days, people would do splenectomy to stage Hodgkin. That's still on the 2000 content prep. We don't do splenectomy as part of our staging anymore. I hope it's not a question, but you should know how to treat somebody who doesn't have a spleen. In terms of late effects, breast cancer in women is the most common secondary malignancy, and that's shown on the left in pink. There's about a 15% 30-year cumulative incidence of cancer. It's highest for females receiving radiation at the age of 10 years or older. The risk does decrease with age, and there's no excess risk in women age 30 or older. The greatest relative risk, however, is leukemia, which is still low, as you can see on the left, but the relative risk is about 160 increase-fold due to the alkylating agents and epipotophylotoxins. I don't know why, but in the content specs, they said, design a retrieval trial for Hodgkin lymphoma. I'm not sure how you make that into a multiple choice question, but the paradigm up until 2017 has been you add a novel therapy, and then you assess response, you know, your CR/PR rate, your CD34 mobilization, and your toxicity after a cycle. If they're not in CR after a cycle, you do it again. If they're still not in CR, you do it again. And you keep going until they're finally in a CR or they progress. If they're in a CR, you go to transplant. That has been the paradigm for how the adults have done it. That has been the paradigm for how the pediatricians have done it. The problem with this model is there are growing data that suggests that a late relapse, so relapse greater than 12 months of a low-stage disease, can be cured without an autologous stem cell transplant, although unfortunately there is no standard of care for that in this country. In addition, patients with refractory disease, disease that's either progressive on therapy or less than 3 months, they don't do well even if they have a transplant. So if I were going to design a retrieval question for the boards, I would focus on these topics, probably in the order that they appear here. I would look at what are some potential targets for immunotherapy, you know, CD30 with rituximab, or EBV CTLs for EBV positive Hodgkin lymphoma, maybe CD20 or CD79A for nodular lymphocyte predominant. I would look at things in the tumor environment. So, for example, blocking Hodgkin lymphoma activation of anti-tumor T cells, like with checkpoint inhibitors. I'd look at drugs that target intracellular pathways, something that might inactivate NF-kappa B or block degradation of I-kappa B, etc. So these are things that I would think of if I were going to try and ask a retrieval question on the test. So moving away from Hodgkin, these are the pediatric non-Hodgkin lymphomas, and again, this is a simplification. I'm not going to talk about the really rare ones, the marginal zone, the folliculars, the peripheral T cells. I'm just going to talk about the ones in the table, and again, they're differentiated by morphology, immunophenotype, and cytogenetics. It's important to know that unlike adult lymphomas, non-Hodgkin lymphoma in children are highly aggressive, disseminated diseases. The epidemiology is shown in this pie chart, with Burkitt being about 40%, the other major players about 20% each, and yes, I know this adds up to greater than 100%. And then the B lymphoblastic lymphoma and the primary mediastinal B-cell lymphoma, a much, much smaller percent. Less than 1% of pediatric lymphoma are secondary malignancies, but they do exist. And again, 60% of these are stage 3 to 4 at diagnosis. So they're highly aggressive, disseminated, high-stage diseases. Non-Hodgkin lymphomas are more common in younger children, again, less than age 10. They're more common in males than females, and they're more common in Caucasians. The incidence is about 4 per million in people less than 20 years of age, so that's only about 800 cases per year in the United States, hence the difficulty with a clinical trial. Burkitt lymphoma is 5 times more common in males than females. The incidence of all of these increases with age, with the exception of lymphoblastic lymphoma. The etiology are unknown, but some of the risk factors include EBV, for example, Burkitt, immunodeficiency or immunosuppression, and certain pesticides. Immunodeficiencies increase the risk of non-Hodgkin lymphoma. This is a list of primary immunodeficiencies which are associated with that increased risk. The buzzwords or the associations that you need to know are T-cell deficiencies result in B-cell lymphomas that are frequently extranodal, and they are frequently EBV-driven. They each have their own distinct histology with some overlap that makes it tricky. Burkitt lymphoma, this is the classic Van Gogh starry sky. You can see sheets of round blue cells that are medium-sized. They have a high mitotic index, and then they've got these little stars in the sky where macrophages are eating apoptotic debris. This is Burkitt lymphoma in the bone marrow. Again, you see the stars in the skies. It's highly proliferative. This is MIB1 staining, and 99% of the cells are positive, so very aggressive. These can double overnight. And so Burkitt lymphoma, highly aggressive germinal cell mature B cell. I talked about the age that it's associated with. The immunophenotype shows B cell markers. Surface IgG is usually positive, and it's almost always IgM. They have low BCL2. The translocations, which are imminently testable if they're testing on facts rather than concepts, are listed here. But notice that c-MYC, the oncogene on chromosome 8, is present in all of them. Other changes can occur. And fun facts about Burkitt's: it's the first human tumor that was associated with a virus, the first with recurrent translocations that were known, and the first to be associated with HIV. A reminder that Burkitt leukemia is treated like Burkitt lymphoma, not like acute lymphoblastic leukemia. There are both sporadic and endemic forms of Burkitt's. The sporadic form is North America and Europe. The endemic form is the malaria belt, so equatorial Africa, Brazil, New Guinea, and Turkey. Burkitt's is about 50 times more common in the endemic areas and occurs a little bit at younger ages in the endemic areas. EBV is only associated with sporadic Burkitt 15% of the time versus 90% for the, or 95% for the endemic. And the presentations certainly overlap, but it's often abdominal mass with lymphadenopathy and then possibly marrow CNS or CSF involvement for sporadic. And then the classic endemic is the jaw mass or the large orbit, and the mesentery and the CNS is involved in about a third. There is a difference in the chromosome 8 breaks in these two. It's near or within c-MYC in sporadic, and it's upstream of c-MYC in endemic. They both express the same type 1 latency proteins. Again, diagnosis of NHL is challenging. You can't rely just on immunophenotype. On the left is Burkitt with a starry sky. On the right is lymphoblastic lymphoma, which also seems to have a starry sky appearance. So the starry sky is just reactive macrophages engulfing apoptotic debris from rapidly dividing cells, and any NHL can have a starry sky appearance. In addition, c-MYC and B-cell markers are seen not only in Burkitt's, but also in diffuse large B-cell lymphoma. So here's diffuse large B-cell lymphoma. You get large cells, you get abundant cytoplasm. There are different histologic subtypes, but we do not currently risk stratify on those in pediatrics. This, like Burkitt's, has surface IgG. It is usually light chain restricted. It does express B-cell markers, and it will occasionally express CD30, which is just nonspecific activation marker in this case. About 2/3 will express BCL6. About a third will express c-MYC. So these are common findings, but not specific findings. It's highly proliferative, but less so than Burkitt's. Two major subsets of diffuse large B-cell are the germinal center B-cell-like, and that's GCL, and that's about 90% in kids. Only about 10% are activated B-cell-like. That's predominantly the adult form, and it has the T1418. The way I try to remember it is adults already know their ABCs, so they have the ABC type. Primary mediastinal B-cell lymphoma, it's about 20% of the large B-cell lymphomas, but it really only accounts for about 1% of non-Hodgkin lymphoma in kids. Unlike the other two that we talked about, these are negative for surface IgG. It does express B-cell markers. It'll frequently express CD30. It has some other recurring abnormalities, including GAIDS and 9P. Interestingly, the genetic profile more closely overlaps classic Hodgkin lymphoma than it does diffuse large B-cell lymphoma. And in pediatrics, it carries a worse prognosis than the other mature B-cell lymphomas. This is lymphoblastic lymphoma. Here you see a lymph node is completely effaced by sheets and sheets of small round blue cells. This is an up-close picture. Again, the lymph node architecture is completely effaced by small to medium-sized cells. There's open chromatin, there's nucleoli, and the lymphoblasts of lymphoblastic lymphoma and acute lymphoblastic leukemia are cytologically identical. These are sheets of TDT-positive immature lymphoblasts, and the point here is TDT is a marker of immaturity. This is an immature lymphoma. Lymphoblastic lymphoma is basically defined as less than 25% blasts in the marrow. If it's greater than 25%, it's leukemia. Like leukemia, it comes in T-flavored and B-flavored. T-lineage lymphoblastic lymphoma is about 75% of lymphoblastic lymphoma, and greater than 90% of the T-lineage are stage 3 and 4. In contrast, the B-lineage, only 10% are stage 3 to 4. The classic presentation is an anterior mediastinal mass for T-cell, and then marrow and CNS involvement do occur. B-cell, it can be isolated nodes in the bones or skin. T cell has T cell markers, B cell has B cell markers. The translocations are better characterized for T lineage lymphoblastic lymphoma. They tend to be translocations involving the T cell receptor gene promoter enhancer regions onto different transcription factors. So look for the TCR alpha delta, TCR beta, TCR gamma genes, and look for genes like tau1, HOX, and LY1. In 2000, currently we don't have a good way to risk stratify T cell lymphoblastic lymphoma the way we do T cell lymphoblastic leukemia. Many of them have Notch mutations, but in 2017, Notch wild type tends to be bad, especially when it's associated with a P10 mutation or loss of heterozygosity at 6q. They tend to do much worse with a less than 50% event-free survival. This is anaplastic large cell lymphoma. In the kind of middle of the slide on the bottom, you see these large pleomorphic cells. The nucleus may actually be horseshoe-like. It's called the hallmark cell, and they can sometimes be multinucleated. This is another example of anaplastic large cell lymphoma. Again, you've got these pleomorphic hallmark cells with a typo, horseshoe-like nucleus, and this perinuclear HOF, or a perinuclear clearing. These are a phenotype that are CD30 positive. They have T cell markers in most of them, but even when they don't express T cell markers on their surface, they all have T cell receptor gene rearrangement. So again, a marker of a mature T cell. The translocation to know is they overexpress the ALK kinase, about 75% of a T25 translocation, which is the nucleophosmin gene, and the ALK insulin receptor tyrosine kinase, and that activates the PI3 kinase and AKT3 downstream signaling pathway. There's a separate cutaneous anaplastic large cell lymphoma. It is CD30 positive, but ALK negative, and this is a separate entity altogether. It is important to know that anaplastic large cell lymphoma can involve the skin and still not be the cutaneous form. I've already talked about the presentation of endemic Burkitt and sporadic Burkitt, but this is your comparison slide between the different non-Hodgkin lymphomas. Diffuse large B-cell tends to present a little bit more diversely. It can involve lymph nodes, liver, spleen, marrow, mediastinum, and often it is extranodal abdominal, so it can involve the bowel and the mesentery and the retroperitoneum. It's often advanced stage at presentation. Lymphoblastic lymphoma will show up with the anterior mediastinal mass, pleural and pericardial effusions, and the symptoms that go along with them. ALCL tends to be a little bit more slowly progressive, can have systemic symptoms. It can involve the organs, the skins, node, or extranodal. It can be advanced in about 2/3 of patient, but CNS and marrow involvement are rare. In the very bottom, it says intussusception is almost exclusively an abdominal Burkitt or diffuse large B cell. So in that teenager with an intussusception, they take it out. It's going to be one of those two. It's not going to be an anaplastic large cell lymphoma. Excisional biopsy is best, but it can be dangerous for some patients, and the diagnosis can often be made from pleural or acidic fluid. I thought I was very clever for the A, B, C, D, E, F, G, H, but the reality is any oncologic emergency can be attributed to a lymphoma. I'll let you guys read these on your own, but lymphoma is always on the differential, and the treatment of these involves treating the underlying cause, usually steroids or chemotherapy, but occasionally urgent radiation. So back to pictures. Here's a four-year-old male with abdominal mass, uric acid of 11, creatinine of 1.1. You see a little bit of contrast in the gut, and you see a whole bunch of lymphadenopathy throughout the abdomen, including renal involvement in both kidneys. And so this patient had Burkitt lymphoma with spontaneous tumor lysis. He was abdominal stage 3. This is a 13-year-old female with fevers, fatigue, and symptoms of a urinary tract infection for which they got a CT. Here's her bladder, and you can see she has frequency and urgency not because she has a UTI, but she's got a large mass right on top of it pushing down on the bladder. And she also had a sympathetic pleural effusion. She had diffuse large B-cell lymphoma, and we diagnosed that from a therapeutic thoracentesis. Here's an 11-year-old with a 10% weight loss, supraclavicular and axillary lymphadenopathy for 4 months. And this is diffuse large B-cell lymphoma of the right axilla and spleen. And I added the part about the 10% weight loss because that is a defining B symptom of Hodgkin lymphoma, but again, you can get these constitutional symptoms even in non-Hodgkin lymphoma. Here's a 14-year-old female with fatigue, tachypnea, palpitation. She had a normal physical exam 5 days prior. You see a large anterior mediastinal mass, a pleural effusion, and a pericardial effusion. This was diagnosed as T-cell lymphoblastic lymphoma from the pericardial fluid. I acknowledge that that is not the least invasive way to obtain a tumor sample, but she was having tamponade physiology and she needed to have that drained. Here's a 12-year-old male with neck pain and facial swelling, so superior vena cava syndrome, and he had ALK-positive anaplastic large cell lymphoma, which was diagnosed from a needle biopsy. And here's a 12-year-old male with a dry cough for 2 months, and he had superior mediastinal syndrome, which is airway compression from paratracheal and mediastinal lymphadenopathy. And this was stage 3 classic Hodgkin lymphoma, diagnosed from a core needle biopsy of an axillary node. And I put this in to remind us that, yes, these mediastinal emergencies tend to be non-Hodgkin lymphomas because Hodgkin's tends to be slow growing, but they can be Hodgkin lymphoma as well. So do we always intubate for airway protection? We should all know the answer to this by now. Your ET tube stops here. Your obstruction begins distal to that. So the answer is clearly no. Sedation can precipitate airway obstruction. This is a patent airway in a 17-year-old alert patient who had a primary mediastinal B-cell lymphoma, but he was sedated for a biopsy of this, and look what sedation does to his trachea. So bad. So superior vena cava syndrome and superior mediastinal syndrome are medical emergencies. You need to proceed with caution. Small tumors can be symptomatic. The symptoms that you get from these are location dependent as well as size dependent. Sedation can cause fatal respiratory failure. Anesthesia can aggravate SVC or airway compression. And it can be very, very difficult to intubate past the intervention. So again, obtain tissue by the least invasive means possible. And emergency management may include steroids or radiation. The problem with starting those empirically before you have a diagnosis is that the biopsy may become uninterpretable in as little as 48 hours. I did include a couple of reviews at the end of this talk on this specific topic. Evaluation for NHL, there are some things we do in the primary care setting, the history, the physical, the labs, including tumor lysis labs, because some of these cause spontaneous tumor lysis, like Burkitt's. Always we do a chest x-ray in the primary care setting, consider a CT. It's okay to do a CT if you have an old enough patient who can lie flat on their back and say, yes, I'm comfortable breathing now. Don't give empiric steroids. And in the tertiary care setting, that's where we could do the CT of the chest and neck, or a CT or MRI of the abdomen and pelvis. We often do a PET CT because that may add some sensitivity, but in general, the CT scan is used for staging. We try to do an excisional or incisional lymph node biopsy. We want to look at histology, flow cytometry, cytogenetics, and molecular studies. We continue to do bilateral bone marrow biopsies and aspirates for non-Hodgkin lymphoma, and we continue to look at cerebral spinal fluid cytology. This is the St. Jude or the Murphy classification of pediatric NHL. Again, I'm not going to read through all of it, but there are some really important differences between this and the Ann Arbor classification, and those are in bold. So stage 1 completely excludes the mediastinum or the abdomen. So stage 1 Hodgkin could be a giant mediastinal mass, but that would automatically upgrade you to stage 3 for a non-Hodgkin lymphoma. And people are still getting this wrong occasionally. I just got a referral where they said it's a stage 2, and I'm like, was there a mediastinal mass? And they said, yes, okay. They were using the different staging system. The other thing to know is that down under the stage 3 part here, all extensive primary intra-abdominal disease, even if it's limited to the abdomen, is stage 3, which is not like Hodgkin lymphoma. In all paraspinal or epidural disease is stage 3, not stage 4. CNS involvement excluding facial nerve palsy or paraspinal disease, that counts as stage 4. So it can be CSF blast, a CNS mass, cranial nerve palsy, cord compression, or parameningeal disease. So in the non-Hodgkin lymphoma, the progression is not orderly and predictable like Hodgkin lymphoma, and that's why we use the St. Jude staging and not the St. Jude or Murphy staging and not the Ann Arbor classification. There's a couple different ways we can risk stratify, but it's always based on the stage at diagnosis, whether or not there's CNS or marrow involvement, and in the BFM system it also uses those, but it also incorporates LDH. In terms of principles of therapies, on the left are the principle, and then, of course, on the right, there's always an exception to the rule. So there's intensive chemotherapy for all. The exception is a completely resected pediatric follicular lymphoma. Now, that's not follicular lymphoma in a pediatric patient. That is pediatric follicular lymphoma, which is a distinct entity invented in 2008, but it's distinct from adult follicular lymphoma. CNS prophylaxis is standard for all, with the exception of a completely resected abdominal Burkitt or large B cell. Therapy is of short duration, and it's very intense, with the exception of lymphoblastic lymphoma, which we treat more like leukemia. We do not give radiation for non-Hodgkin lymphoma. The exception might be CNS lymphoblastic lymphoma on certain protocols, or treatment of an anterior mediastinal mass that's symptomatic and you need to use radiation before steroids. Again, Burkitt's leukemia, treat like Burkitt's lymphoma. Lymphoblastic lymphoma, you treat like leukemia. Survival is very, very high for all, but the worst being primary mediastinal B-cell lymphoma. Chemotherapy is risk adapted. Higher stage get more cycles of chemotherapy and higher doses of chemotherapy. The example here is completely resected abdominal Burkitt gets 2 cycles of chemo, whereas Burkitt's leukemia with CNS involvement might get 6 to 8. It's response-based, meaning we monitor response to imaging, and an incomplete response by CT or biopsy might receive more cycles and higher doses. So the example here is a stage 3 abdominal Burkitt, which we'd put on sort of group B therapy. They're usually in a complete remission after 2 cycles of intensive therapy, but if they're not in remission, we intensify therapy. This is a plug for this website. It is a very good website that has good information about most of the pediatric malignancies, as well as current standards of care. You can get to it by either copying down the long URL number at the bottom, or if you Google either NCI space PDQ or cancer in PDQ, I tried it, it'll get you in one of the top 3 hits. Late effects of non-Hodgkin lymphoma, of course, depend on the type of chemotherapy delivered, but in general, they're going to be secondary things caused by anthracyclines and alkylating agents. So, kind of closing up the talk now, these are the slides that do a lot of the compare and contrasting. So the major differences between Hodgkin and non-Hodgkin lymphoma. Hodgkin tends to be older patients, contiguous nodal spread rather than a systemic disease. We use Ann Arbor versus St. Jude staging. B symptoms in bulk disease are prognostic for Hodgkin lymphoma, although while present in non-Hodgkin lymphoma, they are not prognostic. We frequently use radiation as part of therapy for Hodgkin lymphoma, but not for the NHLs. We do evaluate the marrow for Hodgkin lymphoma, but we use a PET scan for it. For non-Hodgkin lymphoma, marrow evaluation is standard for all patients. Hodgkin lymphoma, we do not evaluate the CSF. We don't do CNS prophylaxis. And flow cytometry tends to not be part of the diagnostic workup, but all of those are important for the workup of non-Hodgkin lymphoma. Again, this tries to simplify the major differences in staging between Hodgkin lymphoma and non-Hodgkin. So stage 1 eliminates the GI or the intrathoracic. Stage 2 for GI, if it's a primary GI tumor and it's 95% resected, that can still be stage 2. Stage 3 crosses the diaphragm for both, but an extensive GI involvement that doesn't cross the diaphragm is also stage 3. And then again, at the bottom, we use B symptoms in bulk disease for Hodgkin lymphoma. I recommend making yourself a cheat sheet. I apologize if this is micrographic in your syllabus. If you email me, I can certainly send you a larger copy. But these are sort of the defining differences between the different kinds of tumors. And I felt this was a helpful way for at least me when I studied for my boards to sort of segregate them and think about what some of the testable things are. Again, it's 2017. Many of these have already been mentioned, but in 2017, these are some of the medications used for the Hodgkin and non-Hodgkin lymphomas that as practicing clinicians we should be aware of. It includes their mechanism of actions and the potential therapeutic use. This is the staging and response criteria in 2017. The Chesson reference talks about using the 5-point PET-based scale. The Chesson 2016 has updated that to take into account the use of checkpoint inhibitors in the fact that when you turn your immune system on to fight a Hodgkin lymphoma, if you do a PET scan too quickly, you actually see more inflammation rather than less. That's called pseudoprogression. So this takes into account that. This is too new for the test. And in the non-Hodgkin lymphoma, there's some revised international pediatric NHL staging system and some new response criteria. And then in terms of general reviews for providers, there's a really good series on the non-Hodgkin lymphoma in the May 2016 British Journal of Hematology. It involves some of the more current knowledge of genetics, and some of it's too advanced for the test, but it's a really good reference for those who like lymphoma. These are the people who have shared slides and information with me, and I'm grateful for them. And these are the attribution of the different slides because different pathologists helped me develop them. That's all I have. So I will take questions. Thank you.